Hi, I'm Justin Benzer. I'm at the Dell Medical School. I'm really new to health equity, and so I've been thinking about what you all have been talking about. So I have a kind of poorly defined question, but let me kind of get to it. So I hear Graham talking about things around spreading, scaling and spreading interventions, and I hear all of this talk about how the health equity is really historically determined, and so probably very complex and locally based, right? And so I guess I can see how you can spread things like Head Start and reducing food insecurity, but I don't really get how you can spread something that is probably very local. Like just thinking about Mississippi versus Massachusetts, the racially based reasons why people aren't getting health care are probably going to be very different between those two states. Or maybe I'm just misinterpreting it. I don't understand it all. So could you clarify that for me a little bit?
Yeah, I can try. So I think a helpful way to think about it is the process for achieving health and the process for achieving health equity are a little bit different from each other. There's a lot of overlap, but there's a little bit of difference there. And I think when we talk about health equity in this country and the processes that people use are really processes to achieve health. And so they're really not necessarily getting at the factors that determine the inequities. So maybe I can use an example. Let's take something like infant mortality, where I showed the data before. So the main factor that determines this disparity that we see between black women and white women in infant mortality is premature birth, so a baby being born too early. And so then you study that and look at the factors that cause that, and we find that it's mostly social causes, social contributors that contribute to that outcome. And then we say, well, okay, so we have these high rates of preterm birth in the African American community contributing to a life course of inequalities and a lot of other health factors. What do we do and what can we scale? So you have to do a couple of things. Number one, you have to remediate the challenges of that premature birth. So you have to bring that baby up to the same level as other children who are born healthy. So that's sort of repairing the damage that happened in the past, because we can't undo the premature birth. And so that's something that's scalable. It might be in the form of better health care and assured health care for kids who are born premature. It might be educational supports to make sure that they have the brain development that they need to catch up to babies who are born full term, et cetera. So these are all things that we know how to do that can be scaled and that can have an impact on that aspect of that disparity causing condition. The other part of the equation is the current risk. So we have this preterm baby and they live in a low-income community. They're exposed to things that cause asthma and so on. So we can remediate that environment and get rid of the causes of asthma that make health worse for that baby, and probably worse if they're low income or if they're living in a inner city, et cetera. So we can remediate some of the existing noxious factors, and that's a necessary component of this process. The third thing we need to do, which we don't do very well, like the first one, we don't do this one very well, is structural change. So one of the things that happens are decisions get made and structures get built around people who are most able, not around people who have challenges. So if you think about a premature baby becoming a child and entering school, how is that school structured? Is it structured to address the needs of that child, or is it structured to meet the needs of the average child? those kinds of structural things make a difference. And we know that as a country because we have Americans with Disability Act. So, for example, you see curb cuts and you see ramps and you see door handles that people with disabilities can use to access a building. So the building is structured in a way to accommodate those who are least able. We need to do the same thing with our delivery of healthcare services, and when we develop these structures to provide care and provide supports, they have to be developed with the needs of the least able in mind. And so these are some of the things that can be scaled and that will contribute to a reduction in disparities. Does that help?
Thank you.
Sure.
Thank you, Vijaya. That was great. Please introduce yourself.
Hi, my name is Catherine Idema, and I work for a company called Health Leads. We're a nonprofit that works to address the social determinants of health. And one of the things that we've recently committed to as an organization is addressing racial inequality both within our own organization as well as externally. And so your question about dancing around the issue of racial inequity is very related to my question. And one of the conversations that we've been having a lot is as we become more comfortable within the organization as colleagues talking about systemic racism, white privilege, white supremacy, we're now beginning to wonder, how do we start to have those conversations with our funders and with our healthcare partners? We traditionally partner with healthcare systems. And so that's been one of the largest challenges, not the largest challenge, but a significant challenge we've been having and a question that we are facing right now.
Great question. Does anybody on the panel?
I'll speak from the provider standpoint. I mean, I think it's something that providers are really look at and find important. You know this as well as I do. You talk to them every day, but I think there are some CEOs who feel like this is a top 3 issue, but in all cases, there is a desire to move this way. And so sometimes I feel like there's this concern of like, is this a third rail issue? And I think right now in especially philanthropy and health nonprofit type stuff, it is something that people want to have raised, and sometimes just like neither side raises because they're worried about it. And so I can only speak from the provider, but I mean, we're launching a cultural competency of care and broader health equity service offering because we're hearing this in the market. So I mean, I feel like leaning into it helps your conversations. That's not really specific, but it just, what we're hearing in the market is I would have them.
Yeah. And if it's helpful, on the buildhealthchallenge.org website, we actually interviewed specifically hospital and health system executives to find out what were their motivations or what was that tipping point that brought them into the build fold, so to speak, you know, and wanting to address social determinants of health in their local community. So that might have some insights for you as well.
There's also American Hospital Association has something, I forget exactly, but it's basically like my organization signs on to be a racially equitable white one, and it's like 2,500 or something providers have signed on. So just if they're on the list, yeah, it sounds like you already know about it.
Please welcome.
Hi, my name is Antoinette Curl. I'm the founder and president of Creative Free Action Lab, and we're a nonprofit that trains Black and Latinx youth to come up with interventions to address racial inequities. And one of the things that we are always talking about are what are some of the barriers of access and barriers of power sharing when it comes to co-creating and collaborating with multiple sectors, and including community members, which we call living experts at the table. I'm interested if you have seen any strategies that works to really have them overcome some of those disparities when it comes to actually getting to the table and then also actually sharing power while at the table.
Yeah, Kelly, I think you might be best suited to address that.
Oh, that's a tough question. We do provide, I mean, you know, in a lot of our programs, we have, you know, a table where we have the community involved and as well as providers. You know, it's just a very simple answer, and it's probably not a good one, but that expectation has to be set, I think, from the beginning for all those that are there. That's the reason that we call them lived experience. What you called them? Living experts. Okay, that their input is valuable and important, and in creating a process by which it's asked for. Also, I think as nonprofits, having living experts be involved at all levels, as well as the board level, is very important. We just recently did that, and it's been quite eye-opening to have somebody with lived experience or lived expert actually all the way up to the board level. I'm not sure that answered your question, but.
I can give one example of a wild failing that I had that taught me a lot, which Emily mentioned sort of outside of my job, some social enterprise stuff. So I live and work with folks coming out of prison to launch businesses and kind of create this idea of an ownership mentality. And we were getting some traction in government and things like that about basically we're trying to pitch some ways that they would support entrepreneurship. And I brought, in essence, our most successful, like 8 to 10 entrepreneurs to a meeting with the deputy mayor, was really going to push on a bunch of things. And it like prepped people, but it was sort of like, let's do this, folks. And the questions that were being asked were the things that, like, probably it was mostly guys. I'm going to say the guys were not really ready to discuss like the nuanced detail of the policy, but were ready to discuss the barriers and challenges they faced and what they needed. And what ended up happening was it was like, oh, that's really nice that you have this cool business, congratulations. And like the ideas weren't necessarily heard. And as we've moved forward, have kind of positioned better on like, hey, here's our policy expert, and here's like this person who's going to talk about the barriers they face to renting to own a building, and here's this. And so it was just like setting people up to be able to speak to what they knew and where they were experts versus kind of like going into the traditional structure of like, I'm going to expect this from you. And so as we're still not great at it, but like that's something that I'm seeing that we could have done better.
And can I add that one strategy is to have dialogue with the community that's not linked to some goal. So, you know, when these outside organizations, whether it's a health department or a hospital or whatever, goes into the community and experiences life in the community and talks to people in the community to learn and to begin to develop some sort of empathy, they engage in better dialogue. So when they're ready to engage in a project together, they already have a base that they're building on. So it's too often that we come in with an agenda, essentially, and so the questions that we ask and the dialogue that we have is leading towards that agenda, and we're not really listening to the whole of what the community wants and needs.
Thank you all. I saw a lot of heads nodding in agreement with that. So I just want to be cognizant of time. We have about 2 minutes left, so I want to make sure we get our last two very patient folks here. Please introduce yourself.
Hi, my name is Nieves. I live in Peru, and I'm in the very early stages of starting an organization of health prevention, since in Peru our health system is terrible. And so I think I can help with that, since I can help with the other. I was just wondering, in your health data, how do you account for all the people that don't have insurance and, like, well, definitely the homeless, like, but there's many people who are middle class in your country that don't have insurance, even. So how do you, how do the health indicators, do they account, are they accounted for in that? Or?
Do you want to answer that?
Well, I'm looking if there are, anybody wants to take that on, but I know, Kelly, you work really closely with the homeless population in LA. Is there an intervention or an approach, some philosophy that you want to share?
To ensure that their data is included, is that what you're asking? Mm-hmm. So pre-ACA, you know, after the ACA, so many more are actually insured. So they are more so counted a little bit more than they were before. Before in OSHPA data and things, they were seen as self-pay. So but to separate them out was much more difficult. So agreed. So we would have to go to the source. For us, like when we did our research to try to move some of our programs forward with the homeless, specifically with hospitals, we had to ask hospitals to self-report, which is not necessarily the most reliable, but that's the way we had to do that. Now it's a little bit easier with the ACA.
All right. And if you all will indulge me, I'm going to sneak in this last question.
All right, I'll be quick with this. So I'm Jen Horancheff, founder of Savvy Cooperative, and we're actually a citizen-owned co-op that exists for much of the reason that Vijaya talked about how to connect citizens with opportunities to share their impact and their experiences. And so my question is, we really try to put forward diverse individuals so that they could hear those perspectives. Do you think that's enough just to have diversity of perspectives at the table, or does there need to be a focused conversation around health equity when these conversations are happening? We work a lot in healthcare with pharmaceutical companies or devices. Does there need to be a separate conversation, or do you see just having, you know, different community members as being at least kind of a first touch point there?
I've found in both sides, when I'm kind of on your side of the table and when I'm on the power side of the table, in each one, that you have to have very specific conversations where you lead, especially the ones in power, towards what is required to support your folks. Like having kind of what I was saying on the previous failures of mine, where like, if we get people in front, then we'll just start, it'll just make it happen. And I can tell you on this side of the table, when I'm like, all right, we need to further the strategic interests of the firm, and we go into city council and we have our lobbyists and we have this and we get $60 million in tax incentives. And then when, like, you know, I'm with my guys, it's like, hey, we should get this, and we don't have as much of the strategy. But when it has been, this is the issue and this is why, and here is this kind of tear-jerker of a story that can tell the, you know, data now behind it, it works. So I cannot say strongly enough that if it's health equity, you push on health equity and probably like 3 levels down on what that means, and then you push on X and Y. I would say as minute detail as possible and specific ask with an individual who can relate life experience as well as then have data behind them. That's what I would recommend.